Welcome to Access Amplified, the podcast where we shine a light on how digital health is increasing access to care and advancing equity around the world. I'm your host, Joanna Brownold, and our podcast is brought to you by TytoCare. In each episode, we sit down with healthcare leaders who are doing the work, not just reimagining access, but rebuilding it from the ground up. Today's guest has been called the father of telemedicine, and with good reason. Dr. Jay Sanders, thank you so much for joining me today.
Thank you, Joanne.
Dr. Sanders helped design the nation's first statewide telemedicine network back in the 1990s, and he is the founding president of the American Telemedicine Association. He's an advisor to NASA, and he's been a relentless advocate for using technology to move care out of institutions and into people's lives. In this episode, we're going to go deep, not into what he built, but into why it mattered. We're going to talk about what health systems still haven't learned from early telehealth models, what truly personalized care could look like, and why the future of medicine is about anticipation and not reaction. So, Dr. Sanders, you helped build the first statewide telemedicine system in Georgia in the early 1990s, and you introduced the concept of an electronic house call decades ago. What part of that model do you think today's digital health leaders still haven't embraced but should? What's missing from today's models?
Well, I think we're slowly learning. I think the hospital at home program is one reflection of that. But what I think that people have forgotten is that the best exam room is where the patient lives, not where the doctor works. And we found that out in 1995 when we were concerned about the fact that patients that we were seeing in rural communities, that a number of them were just constantly being readmitted in terrible status. And we wanted to know why it was we were sending them out of the hospital feeling fine, and then within a number of weeks, they ended up back in our emergency department.
And Dr. Sanders, was this in Georgia?
This was in Georgia.
Okay.
And the sort of antiquated technology that we had in those days was simply the home television set. And we got the local TV provider who had coaxial cable in the ground, no fiber, coaxial cable. We got funding from the US government, and we put in a system that allowed us on a party line
Okay.
to follow approximately 10 patients in our
Okay.
network that were constantly being readmitted.
Okay. So you started with those 10 patients and then kind of scaled it from there?
Well, we did, but there wasn't really much to scale. Remember, it wasn't until 1996 that Marty Cooper developed the cell phone, and then Apple, developed the iPhone.
Mm-hmm.
So we could follow these patients. But I need to tell you that in 1995, when we developed this electronic house call, all of the patients that we had on the system were on a party line.
Okay.
So that in essence, if two people got sick at the same time, we couldn't see both of them.
They couldn't get sick at the same time. That was the rule.
Right, exactly.
Okay. So I think that raises a really good point about, seeing patients where they are. And it also kind of leads me into my next question, because you were really doing this when it was, you ahead of your time and in kind of a very niche setup. And that really was the time at which you helped to create the American Telemedicine Association as well. And what, I would kind of want to talk about that, what the ATA changed, whether it was in public policy or provider culture that made national adoption of these ideas and of these concepts possible.
The reason I'm smiling is that I wish what you just said was true. And what I mean by that is we started the American Telemedicine Association. I'll remember our first meeting that we had. There were 400 people in the room, and I thought the entire world was in the room. At the time, I was so excited that there were 400 people who came to our first meeting.
But I think
it really
for 1995, 100 people is a lot to be discussing these kinds of concepts.
Well, you'd think so, but I was looking at the world
Right.
at the
Okay.
time because while there was lack of access to care in rural areas in the United States, so much of the world is rural. Um, I mean, just as an example, if you look in parts of India, there are people in their communities who don't have running toilets, but they all have cell phones. It's
It's the
ironic.
perfect use case for telehealth.
Yeah. So I think, and I'll be very candid here, it wasn't until COVID that people started looking at and realizing the value of telemedicine.
Uh-huh.
Just a shame. Just a
Yeah.
shame.
It's funny that you mentioned India because my husband's a clinician and he was there maybe 15 years ago. And there was a whole group of them. There were dentists, there were doctors, there were nurses, and he said really the dentists were the only ones who could make a difference in these tiny villages in India. Because, if they need medicine, they need ongoing care. If they have a disease, they need ongoing care. If they need a dentist, they can pull a tooth out and then the problem's solved. So, this is really kind of the case where access and equity are really kind of distancing people and needlessly because they have a cell phone, as you said.
Absolutely. And you just reminded me of something else which was critical. Yes, COVID was instrumental in getting everybody to realize the value of telemedicine, but it would not have happened without the communication infrastructure being
Okay.
put in and 5G communication infrastructure and satellite availability plus the cell phone really made everything come together.
Right. And that's obviously something that was only ever going to happen over time anyway. So
So,
you've spoken a lot about how telemedicine has an ability to close access gaps. But in your view, where has the industry fallen short of advancing true equity and not just convenience?
well, I think the fact that the telemedicine has been able to bring healthcare to the patient has really made us rethink where and when we need to see the patient. One of the problems is that the traditional method of care today, not when I was a kid, and that was a long time ago, but I'll point that out. When I was a child and I got sick, my mother called the physician and the physician came to my home. I mean, that was standard.
Mm-hmm.
Today, when you get sick, you go to the doctor. I think what telemedicine did was to bring us back to when I was young. And
Right.
in effect, technologically, it brought the doctor to me. And that is what I think was important. And that's what stood out to us when we first developed the electronic house call. I really didn't mention this, but one of the first patients that we saw who was constantly being readmitted to the hospital. And we wondered why she used to leave the hospital feeling quite well. And
Mm-hmm.
within a few weeks' period of time, she would have to be readmitted. And we wondered why in the world was that happening. So that's why we figured out we needed to make quotes an electronic house call.
Yeah.
The minute we saw this first patient, we realized exactly what was happening. It was a woman with asthma who was
Okay.
constantly being readmitted into the emergency department in what we call status asthmaticus. Very, very severe asthma, can't breathe,
Mm-hmm.
blood oxygen levels very low, had to be intubated, put into the intensive care unit. Okay, we now see her post discharge from the hospital, and she's sitting in, and for an allergist, they'll immediately recognize what I'm saying. She'll be sitting in this great big puffy chair, which is very allergenic. Okay, she has her pet cat in her lap, and a cat is exceedingly antigenic, and her husband is standing at the kitchen door with a cigarette in his mouth.
So all the triggers, really,
We never wondered again why
right?
she was constantly being readmitted.
And that's the
And
kind of
that's
thing that
when
you
we
never would have known if you hadn't been in her house.
exactly, exactly. And that has led us to the feeling not simply that the home is the best exam room for the patient, but if it is, then we need to provide the technology in the home for the patient to anticipate something is going wrong.
Mhm.
And that's why, and I don't mean this as a commercial, but that's why I was so glad that TytoCare became, um, a business that
Mhm.
was able to supply these technologies into the home.
Yep. And I think it really kind of, as you said, it brings us full circle. So the way that medicine was done for years before, we had big health systems and big hospitals and clinics and places that you had to go was in the home. And you build up this personal connection with your clinician, and your clinician builds up an understanding of you and your family and your circumstances. And I think it's
Exactly.
quite interesting, and I'd love to kind of get your take because a lot of the criticism of telehealth is often about the lack of connection or the lack of personal relationships that can happen like that. And really what you're talking about and what I'm seeing is the opposite of that, right? We're kind of coming back into people's homes. What are your thoughts about those kind of criticisms and feedbacks?
I think you said it all. The fundamental reality is with telemedicine, we can see the patient and see their environment and know so much more about the patient. So the connectivity is dramatically enhanced. Um, and and today, look at everybody in the world, their cell phone.
Yeah.
I mean, that has produced more connectivity amongst people between families than anything else. We're doing the same thing. We're making more connectivity, more connections, knowing more about the patient with
Yeah.
the new technology than we did before this technology existed.
Yeah, I totally agree. And one of the things that I'd love to, speak with you about, you've advised governments, you've advised NASA, you've advised the military. Um, and one of the things that you have worked with them on is delivering care in extreme or constrained environments. And, many health systems do struggle to provide virtual care to patients who are in perhaps more rural areas. What have you learned about delivering care in those extreme environments that health systems could apply?
Yeah, very, very good question. You may be surprised by my response, though. I remember NASA calling me in, and this was in the late 90s.
Okay.
And the then director of NASA, Golden, he had his site on Mars.
Okay.
And we had the capability. So the question was, what were we going to do about what if one of the astronauts got sick? So they called me in with respect to telemedicine. And my first response, and I think they were very sorry they called me, was, well, telemedicine will be useless. And they looked at me with a significant amount of surprise and they said, why? I said, well, you're forgetting the distance. It's gonna it's gonna take minutes. If there's an emergency, it's gonna take minutes for them to hear me say what's going on. And then as I go through the standard history to try and find out what's going on, it's gonna take hours
Yeah. Yeah.
to do
Really, it's
that.
like it'll be like a 12-minute gap, I guess, between the question and the answer. So,
Exactly. Exactly. So, I mean, it's not like you and I talking.
right.
Um, it's a huge delay. And any emergency, which is really why you would need an effective communication technology,
Mhm.
is really totally ineffective. What I suggested, which is really not the focus of what we're talking about, but hopefully will be very, very shortly, is an autonomous robot
Okay.
as one of the
A
okay
robot that was programmed to under.
programmed to each of the other astronauts, knowing their history.
Okay.
And if, for instance, an operative procedure needs to be done, and I'm going to use a specific example, what if, in microgravity, you don't need the strength of the bones that we have here on Earth. So
Okay.
you begin to lose a lot of calcium from the bones. Now, calcium is eliminated through the urine. Well, the
Okay.
likelihood of an astronaut getting a renal stone, and if you've ever had a renal stone, you never want one again. Very painful.
Okay.
Okay. Um, so one of the first knee jerk responses was, okay, well, one of the astronauts needs to be a urologist. Okay. And I said, well, if that's the case, remember they're losing all this calcium from the bone. Even in microgravity, they might break a bone. Maybe
Okay.
we maybe we need an orthopod.
Right.
Well, if you follow that logic, do you know what we finally all decided needs to be done? The most likely medical problem that would occur
In
statistically
space. Yeah.
is appendicitis.
Why appendicitis?
I
Just be
forget the
okay.
rationale, the
Okay.
numbers at the time, but it was appendicitis. So every astronaut going to Mars is going to have a prophylactic appendectomy prior to going.
Wow.
Yeah. So when we got to that point, that's when I made the recommendation that we really need an AI. Remember, this was in the mid to late 90s.
Mhm.
We need a programmed AI robot who could actually do the surgery there on Mars.
Wow. I mean, I assume there's a whole bunch of this. I don't want to get into this too deeply because there's a whole bunch of other follow-up questions that I have about like clean space and how you do that in recovery. But I mean, although I don't know if there's any direct lessons in there for health systems, I do think that if we can work out how to provide medical care to astronauts on Mars, we should be able to work out how to provide medical care to rural areas in, you know, America, in
Exactly.
Nebraska, for example.
Exactly.
I wanna ask a little bit about because you've kind of mentioned this, and AI is obviously developing constantly, and things are changing on a month by month basis at the moment. I would say, and you have written about the concept of a digital medical home. What do you think it would take to turn that vision into everyday practice, and who would that really benefit if we were able to do that?
Yeah, I almost say this jokingly and seriously. We need another COVID pandemic to
Right.
get people to change their minds. But one of the biggest problems is the way we did it yesterday is the way we're going to do it tomorrow. No, that's wrong. I mean, I not only started doing telemedicine in 1969, I was also pushed by another professor of mine to start doing AI, 1969. And the only problem was we didn't have the computer power
Right.
in 1969.
Right.
Today, today we do. What most people forget is the fact I'm going to say something that's going to probably shock your audience, but I'm going to say it anyway.
Go crazy.
Never been accused of being shy. There was a report that came out from the what was then called the Institute of Medicine here in the United States. It's now called the National Academy of Medicine. Changed its name. It came out in 1999, and the title of the report was "To Err is Human." Very benign title
Yeah.
until you read it. And what it says inside is that we wonderful physicians, you ready for this?
I'm I'm on tenterhooks.
We wonderful physicians kill 98,000 people a year on average.
by
Why?
make by making mistakes?
Because we haven't been able to keep up to date.
Wow.
There's new data coming out. And it actually fit with a study in 1980, in the 1980s, which looked at the prescribing practice of physicians 10 years outside of their residency training.
Okay.
And the surprising fact was that they found out that these physicians were still prescribing the same medications they were when they were residents. They hadn't kept up to date in treating the diseases with newer medications. But to top everything off was an article in the British Medical Journal
Mhm.
in 2015,
Okay.
which said that the Institute of Medicine study was wrong, that we actually kill closer to 215,000 people a year from not purposely,
No, of course.
but just by inadvertent medical errors.
Mhm.
We have not kept up to date. And that's why I see with the maturity of the maturing of AI against the constantly updated database
Mhm.
will be the expert opinion that we need.
Right. So, I mean, are you familiar with Microsoft just released some research about what they're calling the medical superintelligence?
I
And they
am.
did. So, I'm wondering how you feel because they also kind of almost handicapped the physicians that were competing with the AI by not allowing them to look up certain, most clinicians that I know, they've got their stethoscope in one hand and their phone in the other hand, to ensure that they're checking the most updated medical advice. They're checking the exact most recent studies on which medication should be given or which drug should be given. Is this the future? And if it is, how soon do we get there?
Well, I think the insurance companies are probably, and the electronic medical record companies, which have a huge problem, which if you ever ask me at another time, I'll tell you what it is.
Okay.
They're not integrated. But what I see is AI programs being integrated with the most up to date medical information,
Mm-hmm.
whether it's Microsoft, whether it's X, Y, or Z company. And by the way, one of the reasons that Microsoft has been a leader in this area is their chief scientific officer. He used to be their chief medical officer,
Okay.
Dr. Eric Horvitz. Eric has been a leader in AI since the mid 90s, and now he's their chief scientific officer. So I applaud what he's doing,
Mm-hmm.
although quite candidly, there may be even better systems out there, and there will be. I think if they were correlated with the most up to date information, and they should be, that's going to be the pattern for the future.
Right.
You may have your individual physician, but your individual physician will be taught and will be updated constantly. So he or she will be putting this into their AI device and be given the most up to date information.
Mm-hmm. Yeah, I think that integration is so essential. And moving away from AI, or maybe not, depending on what your answer is, you built a statewide digital system in 1991 in Georgia. If you were doing it today from scratch, 2025, what would you do differently, and what might you do the same?
Oh, well, first of all, the having the connectivity um, is
Would
number one.
change, right?
That's number one. The In 1991, connectivity were T1 connections because there wasn't 5G in
Right.
1991. We didn't have that capability. But today we have as much connectivity as we'd want. Number two would, when the patient was calling me, they would first be speaking. I know this sounds impersonal, but it's safe. They would first be talking to an AI database,
Okay.
taking their history. And
Okay.
as you know, I know it's standard in the United States. You're a new patient. You walk into this to see this new physician. What's the first thing that the secretary at the desk does? She hands you a clipboard for you to check off
Mhm.
6 million ridiculous things. Okay.
Which is then inputted manually into a computer system, which
Yeah, that's ridiculous. I would sit the patient down in front of an AI driven computer asking, what's your chief complaint? Why are
Mhm.
you here? And then through a branch logic tree with the AI device, taking them through their history and coming up with a differential diagnosis
Yeah.
to hand to the physician when the physician sees the patient, as well as the laboratory tests, the radiological tests to order to rule in or rule out the specific differential diagnosis.
Yeah.
Think about how much time that would save the physician. Think about how much more specificity that would provide to the type of testing done.
Yeah.
Think about the reduction in the amount of economics that somebody is going to have to pay
Mhm.
because it's much more focused type of differential diagnosis and testing that needs to be done.
Yeah.
That's the way I see tomorrow's office. But I really view, quite candidly, the true doctor's office being in the patient's home.
Yeah. Yeah, but I mean, and again, not to kind of self promote, but with tools like Taito, that's something that that we can do now. And I think, again, bringing that back and saving that clinician the time. There is a huge clinician shortage across the world. If the clinician can see two patients instead of seeing one patient, then
Exactly.
that's a great opportunity, and it's a great way that tech can help intervene to solve some of these challenges. Okay, I want to ask you a bit of a kind of personal question to wrap up. You've been working in telemedicine for over 50 years, which is that's the only time I'm going to say that sentence ever in my life.
Thank
Um,
goodness.
what inspires you? You're still going strong, and what are you most proud of in your work?
Interesting question. I think the best answer is I'm so proud that after my initial thought about what my professor said to me back in 19 was actually 1967 when he first raised the issue of getting two black and white TV and solving his traffic problem in Boston between Logan Airport Medical Station and the Mass General ER. And he asked me what I thought about his idea. And I, of course, immediately thought it was the stupidest idea I'd ever heard of in my life. And by 1969, we had the setup in the emergency department at the MGH, and we were examining patients over TV. And I said, wow, this is really interesting. And then when I went from the MGH to the University of Miami, because I couldn't stand the gray skies in Boston and I loved the sun. And I got a grant from the National Science Foundation and used telemedicine to study the quality of the care provided by on site physicians versus nurse practitioners using telemedicine and showing that the nurse practitioners using telemedicine did as well as the board certified physicians physically on site it became obvious to me that, wow, this is a solution for our healthcare delivery system.
Yeah. And you've really pushed that forward and pushed that through and made such a difference to the way that we access care today.
But I give all the credit to one, my professor, Dr. Ken Bird, and to the governor of Georgia in 1991, who said, I want you to develop a 59 site connected healthcare delivery system in Georgia.
Um, Dr. Sanders, thank you so much for taking the time to chat with me today. Every conversation we have is a pleasure, and I learn so much from you every time that we speak. So thank you very much.
Thank you for inviting me. I appreciate it.
If you enjoyed today's conversation, please be sure to follow or subscribe wherever you get your podcasts. New episodes drop every 2 weeks. Please share this episode with a colleague who's passionate about digital health access or rethinking care delivery. Access Amplified is brought to you by Taito Care. I'm Joanna Brownold. Thank you so much for listening, and we'll see you next time.